Yeah, as you know, this is today WHO 1991 to declare is World Diabetes Day. As a proud Canadian, 100 years of Canadian lionism, today is the historical event. I would like to welcome all of you on behalf of District A711, Governor Thibault's team, and also my Diabetic Awareness Committee to welcome you to join this evening. As you know, diabetes is a very alarming situation for many communities around the world. As of today, 422 million people are somehow affected by diabetes, 1.6 million deaths occurring yearly, so which is 3 or 5 times higher than corona, what we are afraid of. So we need a long-term prevention and control measures. That's why we need education. Education is the solution. Because we know diabetes not only sugar control, diabetes also matter to how to control or manage your weight, obesity, or food or activities. How can be active in your life? How can you change lifestyle, even only not the lifestyle, as a holistic viewpoint. Today we have a very young star, 4 young stars today are going to present, and momentarily we'll go from our introduction as we do. We need to start O Canada as we Lions all do. I would like to ask Agafaya to start O Canada.
Oh, Canada.
Thank you, Agafaya. Thank you, Nabila. So sorry for a few second delay, and I would like to share with our today's agenda, so that you can imagine what to expect today. So we just finished our O Canada, and I would like to now go with the short note and introducing our guests, especially PDGs and our guest, and also finally our speaker will start their speaking after the introduction of the guest and message from district governor. So as you know, we started this from last July and is a historical event. Today is the 5th iteration of this kind of seminar at District A711. We covered what is diabetes, fundamentals of diabetes, ABC of pediatric child care, and healthy talk in terms of mental health and diabetes. We also talk about sleep and diabetes and looking through your eyes, your body. And today we have a very young star presenter from UK. I can see Dr. Manu is here, and Amena, Nafisa, and Sudipta. They all talk about varieties of topics. So ranging from clinical and social behavior, lifestyle, not only lifestyle, whole holistic approach. So we will learn from them. And before going to that, I really am very thrilled today that you, even though Diwali and other events going on in this difficult time, you make your time to join us, to encourage our Lions to organize this kind of thing. as an ongoing basis because it's a learning curve. So we all learn from each other. And I would like to go to just introduce our District Governor, Lion Thibault, in this point, and to ask him to give his welcome remarks briefly. Governor Thibault.
Thank you, Lion Dr. Shafi. It's always a pleasure to join you for these diabetes presentations. Past, present club, district, and international officers, Lioness, Leos, fellow Lions, distinguished guests, greetings. It's a pleasure to greet you this evening on World Diabetes Day. This month is celebrated as World Diabetes Month by Lions Clubs International. And as you know, diabetes is one of the major causes that Lions support. So we are really happy that Lion Dr. Shafi has chosen to present his monthly diabetes presentation on this day, World Diabetes Day, November 14. Give Lion Dr. Shafi a round of applause. Thank you. So yes, we want to welcome all of you. Thank you for taking your time to attend this session. I've attended all 5 sessions so far, and I look forward to attending all the others up until next year and beyond. And I invite you to listen attentively. Thank you for your attendance and for your attention. Thank you, Lion Dr. Shafi.
Thank you, Governor. So we have several past district governors. Today, I would like to just thank Governor Lion Dr. K. Min and Lion PDG Lion Ola. And I think I have 3 or 4 screens. I have difficult to find other governors. Maybe Governor Harold and Governor Jeffrey always they join us. And we have also district leaders, different club members, my fellow international trained doctors, and my friends and family. Without further delay, because today we have a 4 speaker, I would like to save the time to give for the speaker to present their knowledge with you so that we can be much educated than before. Every day we're learning, as Governor is saying, every day we should learn something for better life, for better future, and all for one, one for all. Without further delay, I would like to ask Nabila to introduce today's first speaker.
Thank you, Dr. Shafi. Dear audience, I'm going to start by introducing our first presenter of today's session, Nafisa Bhuiyan. Nafisa have completed her BSc in Neuroscience and Human Biology at University of Toronto in 2018. She is currently completing her 3rd year of medical school at Auckland University William Beaumont School of Medicine in Michigan, US. Her interests are public health and women's health. She volunteers at Michigan Street Medicine Program, providing free healthcare screening and local homeless shelter, as well as World Medical Relief Charity, helping to organize free medical supplies for donation to both developing and developed nations. Thank you, Nafisa, for joining us today. The floor is yours now.
Hi, everyone. Can you hear me?
Yes.
Okay, great. Thank you so much for letting me join this session. I really heard so much about Lions Club from my dad, so this is an honor. And thank you for such a nice introduction. And thanks for Agafia for organizing my presentation schedule and everything. So I'll start by sharing my screen. Can you guys see it?
Yeah, you can make it as a projector mode. Yeah.
Yeah. Is this good?
Yes.
All right. So today I'm going to be talking about type 2 diabetes and more of the medical management side of it. As a 3rd-year medical student, I see a lot of patients with diabetes starting this year since we started clinical rotations. And I just want to share things about diabetes that you probably not are familiar with before, but I know you guys are all very well versed in diabetes because of these seminars. So many of these might be repetition, but I hope you learned something new from them. So the agenda for today is to introduce what diabetes is, how we diagnose them, what the characteristics of diabetes are, and I'll go more in depth into the different medications for diabetes other than insulin, and some acute complications of diabetes, things that actually brings patients to the hospital, and a brief overview of the complications. So just a brief summary of how you get diabetes. Many of you are already familiar, but I just want to provide my own analogy to go with today's presentation. So normally you'd expect when we ingest food for it to be broken down into glucose in our body. And that glucose builds up in our blood outside the cells. And we have this organ called the pancreas that secretes several hormones. One of the hormones is called insulin that promotes glucose to go inside the cell. So you can think of insulin as a key to get into the cells. And normally, if you have that key, you can regulate your blood glucose by trapping that glucose inside the cell. But for diabetes, the problem is that key either doesn't work or it's not there. So if it doesn't work, we call that insulin resistance. You're trying to get through into the cell, but the key is wrong or it's not working because the cell is used to having insulin so much, it's resisting. Or after the pancreas gets exhausted from making so much insulin, the pancreatic cells just stop functioning. So that's called progressive beta cell, pancreatic beta cell failure. So we get diabetic symptoms if the key's not there or if it's not working. So that leads to hyperglycemia or high blood sugar. So that's the symptom component, but how do we actually categorize patients into patients with diabetes versus patients without diabetes? There are many ways, and I highlighted the 3 here, and I'll talk about 4. So one of the ways is measuring fasting plasma glucose after an 8-hour fast. So you can, if you have fasting plasma glucose level over 126, that's diagnostic of diabetes. Or you can take an oral glucose tolerance test. You drink a special sugary drink, and we measure the blood glucose before and after the drink. And if it's over 200, that's also indicative of diabetes. You can also do a random blood glucose, and if that's over 200, that's also indicative of diabetes. And most of you are also familiar with hemoglobin A1C. If it's over 6.5%, that's indicative of diabetes. So I know we talked a lot about lifestyle, diet, exercise in the past, but what do we do as medical professionals if those fail, or those are not, lifestyle modifications are not enough to control some of the severe symptoms? Then we add medications. Before we start insulin, we want to add more non-insulin anti-hyperglycemic drugs, most commonly within 2 to 3 months of diagnosis. So there are many classes. You've heard of Metformin. There are many types of insulin-releasing pills that I'll talk about today. You have TZDs, starch blockers, incretin-based therapies, amylin analogs, many different types. And the last line is also insulin. But let's say you did an hemoglobin A1C and the initial value ended up being 8.5, which is way higher than 6.5 value. Then we start metformin, which is the first line drug, immediately. Then we continue adding other anti-hyperglycemic drug until we reach the desired hemoglobin A1C. And if insulin is needed after the non-insulin drugs fail, then we start with basal insulin, which is a long-acting insulin that's given once a day, and it's usually given at bedtime. So just to talk about metformin, this is the first line therapy for diabetes type 2. And it's so effective that it can be given to pre-diabetics. It's more tolerable and more convenient for patients because it's taken orally instead of insulin, which is injected. Common brands you might recognize are Glucofad, Riomed, Grumetza. It's nice because it's pretty affordable because of its widespread use, I assume, and it helps reduce weight. The main way metformin works is by decreasing your liver's glucose production. So other than when you ingest glucose, our own body makes glucose. And the number one organ that makes glucose is the liver. So if you can target that, then it's a very effective way to control your body's glucose level. And because metformin is not related to insulin, it doesn't act like insulin, it doesn't give some of the bad side effects of insulin, like low blood sugar. But because it targets the kidney and the liver, we don't really want to give it to patients with liver failure or kidney failure because of the rare side effect called lactic acidosis. So lactic acids are usually secreted by the kidney, and if that's not functioning, it builds up in your body. So that's metformin. Another class of drugs is called glucagon-like peptide 1 agonist. I'll just call it GLP-1 agonist. If you hear of drugs that ends with the suffix tides, dulaglutide, exenatide, liraglutide, you'll know it's GLP-1 agonists. So the function for GLP-1 agonists is different from metformin, but it helps promote insulin. That's why I have lots of keys at the side to symbolize the fact that incretin makes the pancreas secrete way more insulin so that insulin can work more to bring in glucose into the cell. And because it's insulin related, it does cause low blood sugar, so that's something we should watch out for. Most of the GLP-1 agonists are injected, similar to insulin, except 1 or 2. And it's also a good drug for patients who have cardiovascular disease. So it's like a 2-in-1 drug. If you have prior history of blood clots in your heart, if you have history of heart failure, this is a good drug. But because GLP-1 agonists make the pancreas produce a lot of insulin, one of its rare side effects is pancreatitis, which is an inflammation of the pancreas. So that's something physicians watch out for. Another class of drugs called sulfonylureas work very similar to GLP-1 agonists. Some of the generic names you might recognize are glyburide, glipizide, glimepiride, anything that ends with an ide. That's a sulfonylurea. It's similar to GLP-1 that it makes the pancreas secrete more insulin, but one of the bad side effects of sulfonylurea is that it can cause weight gain, which is unfortunate. That's not what GLP-1 does. Since it's related to insulin, it can cause low blood sugar. And similar to GLP-1, it's good for patients with cardiovascular disease. The other disadvantage of this drug is because it's making the pancreas work a lot more, your pancreas gets exhausted. So after 1 or 2 years, sulfonylureas are not really good at doing their job. So they begin to lose their effectiveness, in which case you have to switch medications again. Other type of drugs work in a different organ entirely, not the liver, not the pancreas, but the kidneys. They are sodium glucose cotransporter 2 inhibitors, or SGLT2 inhibitors. They work in the kidney and they prevent the reabsorption of glucose in the kidney. So drugs like canagliflozin, dapagliflozin, and pagliflozin, anything that ends with the flozin, are SGLT2 inhibitors. So normally, your kidney senses that you're losing glucose in your urine. And normally what they do is grab that glucose and keeps it in the body. What this drug does is inhibits that transporter. So it lets your kidney let go of that glucose. That's a good way to pee out glucose, literally, to reduce your total glucose levels. It's a little bit more expensive drug, but this drug is becoming more popular, at least in the US, because recent papers showed that it is very good for patients with heart failure. They're considering using this for patients with heart failure who doesn't even have diabetes. So it's a very 2-in-1 drug. But the fact that it promotes glucose excretion in the urine, it increases your risk of urinary tract infections, vaginal yeast infections. That's not very common, but theoretically, doctors think that if you have lots of glucose in your urine, that promotes bacteria to grow in the genitourinary system. So that's, if a patient has a very high, long history of urinary tract disease, we tend to avoid this drug for them to not make their symptoms worse. And then we have insulin. I know most of you are aware of insulin, but insulin comes in very different formulations. There's short-acting insulin, there's intermediate-acting insulin, there's long-acting insulin, and what's called a pre-mixed insulin. That's a combination of short-acting and intermediate-acting. So when do you use short-acting? Because it has such a short half-life, just like the first bar you see, short-acting insulin such as Lispro and Aspart. You might have heard of Humalog, Novolog, anything that ends with the log. Those are short-acting. We give them typically after meals so that you prevent the high spike in blood sugar just right after breakfast, lunch, and dinner. So you can give these short-acting drugs after 3 times a day, after meals. And then you have the long-acting insulin, like Detamir, Glargine, Degludac. They're given once a day. They just reduce your overall insulin level all throughout the day. The baseline baseline glucose level is lowered with the long-acting, given usually at bedtime. So that when you wake up, your starting glucose level is lower than if you didn't take it. And there's intermediate acting insulin, like it's called regular insulin. Pre-mixed insulin is a combination of the short-acting Lispro, Aspart, Glargine, and regular. So that pre-mixed insulin can have 30% short-acting and 70% regular that can be injected. It's kind of an in-between thing. You also have insulin pump. If you don't want to regularly inject yourself with insulin, the insulin pump monitors your blood glucose and administers insulin when it sees that your blood sugar went up a lot. So that's an automatic function. So in the doctor's office, the reason why we have regular checkups with diabetic patients is because the dose and the frequency of insulin, it can change for each patient depending on the blood sugar level at each time point in the day. So if we see that there's high morning blood sugar, what we can do is we can increase the bedtime long-acting insulin so they don't wake up with the high sugar. If you have high blood sugar after meals, then you can administer the short-acting or increase the short-acting or give the regular-acting more. Or if you have high blood sugar right before going to bed, you can give the intermediate or regular-acting or increase the intermediate regular-acting insulin. So those are just example scenarios. There are many, many, individualistic problems that patients can come up with, and physicians are trained to tailor medication management, lifestyle management to whatever the patients need. So but these are examples. We hear of chronic complications of diabetes a lot, like I'll talk about later, like diabetic retinopathy, diabetic nephropathy, ulcers, foot ulcers, but we don't know, well, at the general public, don't really know much about some acute complications that can bring patients to the hospital. I'm sure you've heard of diabetic ketoacidosis. That's usually more common in type 1 diabetics. But type 2 diabetics, we worry about hyperosmolar hyperglycemic state, which is when your blood sugar is very, very high, like over 600 random. So if you remember, we said over 200 is a diagnostic of diabetes. If you have 3 times that amount, that's a state of emergency. Other acute complications are life-threatening hypoglycemia. So especially for patients who take insulin, sulfonylureas, if you don't regularly go to the doctor to manage the appropriate amount of insulin, you will risk getting low blood sugar, which comes with its own host of problems. And sometimes it can be, the symptoms of hypoglycemia can be worse than typical symptoms of hyperglycemia. And since we're in a COVID pandemic, we've seen evidence that type 1, type 2 diabetics do not do as well if they have a concomitant COVID infection. So we'll talk about that briefly. So I talked about hyperosmolar hyperglycemic state. I'll just say HHS. So it doesn't occur overnight. It usually takes about a few days, a couple of weeks to build up to that state. It occurs in type 2 diabetics because type 2 diabetics are more likely to get that high of a sugar level. And that leads to your blood being very, very concentrated with sugar. And it doesn't happen overnight because it's usually triggered by certain things that trigger your body to build up the blood glucose. So things like heart attack, heart failure, some drugs can cause it, like steroids, glucocorticoids. If you take, not all the time, but sometimes, these can trigger your body to produce more more glucose. And if you're not taking your insulin medication correctly, or if you have some traumatic infectious event in your body, like pneumonia, urinary tract infection, if you had a recent surgery, if you had a burn, if you underwent dialysis, these kind of things can trigger it. Not all the time, but sometimes. Patients with HHS typically still has some amount of insulin, but it's nearly not enough to control the high blood sugar. So how do you know if somebody has HHS? So they show up with some of the typical symptoms of diabetes, but even more severe. So we know that diabetic patients get polyuria, which is when they urinate a lot more and a lot more frequently. They're more thirsty. And because they're losing so much fluid, HHS symptoms include dehydration. So they'll have very dry mouth, dry skin. They will look visibly sick. And because it's a traumatic event, you might see slight weight loss in a few couple of days before it's diagnosed. And you also see glucose in the urine. The most severe complication we're afraid of with HHS is the altered mental status. So the mechanism for that is because your body fluid's so concentrated with glucose, your brain actually shifts brain cells shift some water from inside the cell to outside so that it's less concentrated. Because of that, your brain cells literally shrink up to compensate for the fact that they don't have enough fluid in the cells to move it to outside the cells to balance out the high blood sugar. And that shift causes confusion, sleepiness, and worst case scenario, it can cause coma. And another side effect of HHS is losing a lot of vital electrolytes in the urine. So electrolytes like potassium that you lose in the urine. And the treatment for HHS at the hospital is to give IV fluid immediately. That's the first step. Dehydration in any patient is the worst case scenario for all organs. So we want to hydrate the body as much as possible. And next we give insulin. Well, for obvious reasons, we want to control the blood sugar, but we want to give IV fluids before we give insulin. And because our body is losing potassium, and because insulin can sometimes lead to low potassium, we want to give our patients IV potassium as well. And I talked about COVID. So many papers published recently show that having type 1, type 2 diabetes unfortunately increases your risk of mortality with patients who are hospitalized with COVID. Same with patients with higher hemoglobin A1C, high BMI, have a higher COVID mortality risk. And some of the chronic complications of diabetes I talked about are diabetic retinopathy. So your blood vessels behind the eye can get clogged up with blood sugar that attaches to the vessels. That's why diabetic patients are encouraged to go to their ophthalmologist to get yearly eye checkups so that it doesn't eventually lead to blindness. You get diabetic nephropathy when you have your kidney stops functioning because of buildup of sugar in the kidney blood vessels as well. That leads to them not being able to function normally, which is why you get a lot of urine in the, you get a lot of blood sugar and you get a lot of sugar in your urine with late stage diabetes. And diabetic foot and ulcers are common because the blood sugar clogs up the extremity, the blood vessels in your fingers and your toes. That leads to low blood supply. So if you get a slight cut, because you don't have a low blood supply enough to heal as fast, that leads to diabetic foot ulcers. That's why if you go to a doctor as a patient, diabetic patients get frequent foot checkups. You get diabetic neuropathy, which is when you don't get when your nerves don't function as well because they're not getting enough blood supply. So you get tingling in your fingers, you get numbness. That's diabetic neuropathy. So that is the end of my presentation. I know that's a lot of drugs, but I wanted to give some new information in case you guys haven't heard of it. But thank you so much. If you have any questions, if you want to reach out to me, that's my email, bhuiyan@oakland.edu. Stop sharing.
Thank you. Thank you so much. Now, Alliance, you understand why I'm so proud of? Because
Yes,
Nafisa is a brilliant young medical student. I hope she can help us in future to control our lives better, especially diabetes and aging care. So now, for the sake of time, I would like to ask one or two comment or feedback if you can make quickly, and then we can go for the next presenter. And after all 4 presentations, we will start about common discussion. So any experiences, we have a lot of experienced people here. We can listen from them.
I would just like to say it was a very nice and informative and crisp presentation. Congratulations. Thanks.
Thank you.
I really enjoyed it as well. It was very precise and to the point, and I'm so happy to learn about the updates in management. Thank you so much, Nafisa. It was very well done.
Thank you so much.
So I'm saying none. Any one more comment? Anybody want to make?
Yes, Assalamualaikum.
Yeah, you go ahead.
Okay, no problem. You can go. You can say no problem.
Actually, I didn't expect her presentation would be this nice. Like it was really interesting. Thank you so much.
Good. Sonia, Dr. Sonia. Oh, Dr. Lion Soraya. Please go ahead.
Yes, yes, I'm Dr. Sonia and Dr. Nafisa. Congratulations, it's a very nice presentation, and overall presentation was too much lively. So, no wishes for your future, better future, inshallah.
Thank you.
Yeah,
Lion
I think, yeah, it was a nice presentation. I'm an insurance and investment advisor. We always look at the medicines, but what is the behind the scene, why they are using, it was so informative. Okay, thank you so much. Okay, thank you so much for all the team. Thank you.
Let's give a applause so that she can learn more and future she can help us and she can join future
May I
lounge.
say, may I say
Yes, a big
something?
hand for her.
May I
Laila,
say something? Dr.
very quickly.
Nafisa, it was an excellent presentation. I learned so much. I love that you went through the various drugs and what the impact is on it. You also have a beautiful voice and you spoke at a wonderful pace. So it was a joy to hear. Thank you so very much.
Thank you very much, everyone. Thank you.
Thank you. Okay, so our next presenter, I would like to, who is going to introduce?
I'll introduce.
Please go ahead.
So our second presenter for today's session is Dr. Manu Raj Mathur. Dear audience, Dr. Manu is a dental surgeon with a PhD in epidemiology and population health from University College London and a master's in public health with specialization in epidemiology from the University of Glasgow, UK. He is currently working as a head of health policy and additional professor as Public Health Foundation India, New Delhi, and as a senior lecturer in dental public health at University of Liverpool, UK. He has been a recipient of a prestigious Fogarty International Clinical Research Scholarship for the year 2010-2011 for his doctoral study and Wellcome Trust Mid-Career Fellowship to undertake work on psychosocial determinants of oral health inequalities in India. He is a commissioner on the recently constituted Lancet Commission on Global Oral Health. He has more than 100 publications in leading international journals, and his area of expertise lies in advanced epidemiologic methods, operation and health system, and policy research and health promotion. He is currently leading several large-scale projects from MRC UK, Global Bridges Consortium, and Government of India. Dr. Manu, it's our pleasure to have you today. You are welcome to step in, please.
Thank you.
Nabila, so I just want to add one thing. Today's all presenters are proud Canadian. Dr. Manu is not exception. He is a Canadian working in England now. Dr. Manu, go ahead.
Thanks, Dr. Bhuiyan. Thanks for the introduction. And thanks for inviting me. Hello, everyone. I hope you all are staying safe and doing fine. I'm right now in Liverpool and it's 12:30 a.m. in the morning. Happy Diwali to those who are celebrating Diwali today. We are in lockdown and we have the dubious distinction of being the city with the highest infection rates in Liverpool, in United Kingdom right now. So what I'll do is in the next 10 to 15 minutes, what I'll try to do is I'll try to develop or establish a link between oral health and diabetes. After an excellent presentation by Dr. Nafisa on what are the various pharmacological aids available for diabetes, it is important to understand what are the various comorbid conditions or what are different conditions which are associated with diabetes, which leads to exacerbation of diabetes or where diabetes leads to certain systemic complications. And one of the major systemic conditions which is affected by diabetes or which is associated with diabetes is oral health. Just to give you an example, and this is interesting because Lion Surya was talking about he being an insurance, he's from the insurance sector. You hear about a lot of medicines, you hear about a lot of diseases which are covered under insurance. And oral diseases are something which are not covered by many insurance companies all over the world. So the treatment of oral diseases is both extensive as well as expensive. And as per some of the estimates, it constitutes about 5% of the total expenditure on health. It can affect anyone, anytime. So it can start as young as 18 months when you start getting your first dentition, or even before that. And it can present at any stage of your life course. Almost half of the people across the globe are affected by oral health. And they are one of the most prevalent conditions globally. So these are one of the most common diseases, which are often ignored because until and unless you start feeling pain or discomfort, you don't go to a dentist, or you don't really feel that these are problems. Now, before I go into the details between the linkages between oral health and diabetes, it is important to know where the world is going on, with oral health. So there are these two world maps in front of you right now. One is from 1990 and the other one is from 2016. And what I want to show is that, let's not go into the details of this, but just look at the colors. It is becoming darker. It is moving towards the yellow and the orange side, which shows that the disability which is caused due to oral disorders is increasing globally. So people are becoming more and more disabled due to oral diseases. And along with cardiovascular diseases, diabetes, and cancer, this is the only condition which is worsening with the advent of time. And this is something which we have to worry about. If you look at Canada, for example, it was light green and now it is somewhere in the orangish shade. And the oral health in Canada is actually poorer than the oral health in the United States, for example. So this is something really which has to be, taken into cognizance and something to worry about. And as I was mentioning, the impact of oral diseases is not only, pain, discomfort, or lack of self-esteem, or sleepless nights, or fear of sitting on a dental chair. It goes much more beyond that. Oral diseases can lead to social isolation. It can lead to time off work, time off school. It leads to compromise in social attractiveness. So there are various professions which require you to have a very good set of dentition. And all of these on a larger scale leads to reduced productivity of workforce. It leads to a lot of cost on the national health system, and it can lead to poor educational performance. So it has got a very, very strong impact on the sustainable development of a nation. What we are seeing in 21st century is that the population all over the world is aging. And this is mainly due to many things. We have got advanced medical technologies in place, life expectancy is increasing all over the world. And this aging population has got a strong impact on the increasing number of people suffering from diabetes. So we have got an increasing population now which is suffering from diabetes. And this aging population has got a direct impact on oral health also. Now, what is happening is that there is a bi-directional relationship between oral health and diabetes, and both of them are putting each other at threat. Again, some statistics. This is important to know because what I have done is here, I've looked at number of cases of diabetes in countries in 2011 and what is the projection in 2030. And you can see that it is the developing countries of the world where the most concentration of diabetic patient is located. And if you look at the column on the right, most of these are the countries from where people migrate. So they carry the disease, they suffer from diseases, and wherever they go, they are the people who are worst affected by diseases, like diabetes. And this has got an important, very, very important impact on the kind of services which are offered or the kind of support which they can get. We all know that risk of diabetes increase with increase in dietary sugar, with increased level of smoking, higher alcohol intake, higher stress, being overweight, and due to lack of physical inactivity. What is important for us to understand is that for all non-communicable diseases like diabetes, there are a set of common risk factors. Now, if you can control these risk factors, you can not only control diabetes, but you can control a number of these chronic or non-communicable diseases. So for example, if you have a healthy diet, you can not only control your weight, you can reduce obesity, but you can also help in reducing cancer incidence. You can help in reducing your risk of heart diseases, and you can also improve your oral health. So when we are talking about people living with limited resources, and you can't just spend money on each and every disease condition, it is very important to control these risk factors. Because if you control these risk factors, you just not only are controlling one disease, but actually a set of chronic diseases. And this is very important to keep in mind. So coming to the discussion today, there are links between diabetes and oral diseases. Diabetes actually can lead to a number of oral diseases. Dr. Nafisa pointed out towards dry mouth, which is reduced salivary flow. And this is a very common disease where you constantly get the feeling of dryness in your mouth, which leads to difficulty in chewing or swallowing food, and can lead to a massive reduction in weight and massive nutrient malnutrition. Uh, Diabetes can also lead to diseases of gums. It can lead to inflammation of gums, bleeding from the gums, and it's very common in diabetic patients. You see bleeding gums or swollen gums. It can lead to root caries. Basically, this is the decay of the roots of the teeth, and this is due to the resorption of the gums, which can lead to root caries. It can also exacerbate oral candidiasis, which is a fungal infection which is caused by high blood sugar or salivary dysfunction or impaired immune system in the body. Diabetes can also lead to pulp abscess or necrosis, or just the degeneration of the pulp of the teeth. And the pulp is the only vital organ in the teeth, and it can lead to degeneration of that vital organ, which can lead to premature falling of teeth. It can also cause delayed wound healing. So if you have got any kind of wound or any kind of scar in the mouth, it can lead to vascular dysfunction, and it can lead to prolonged bleeding from these wounds. And this is a very important manifestation, because if you have diabetes and if you go to a dental clinic or to a dentist for some kind of treatment, they'll have to be extra careful in managing you, because a diabetic patient is more prone to delayed wound healing. Now, coming to some of the science which links periodontal conditions with diabetes. Now, I will try to explain this. These are all evidence-based scientific facts, but I'll try to explain how these are important to you and why these are important for you to know. In people who do not have diabetes, or people without diabetes, there is a very strong evidence that inflamed gums or diseases of the gums leads to worse glycemic status. So if you have got inflamed gums or any kind of disease of gums, it can lead to higher glucose levels, higher blood glucose levels. There is also evidence that in people suffering from type 2 diabetes, if you have got periodontitis, then it leads to poor glycemic control or poor control of blood sugar. Also, if you have got periodontal conditions or disease of the gums, it can lead to a lot of different diabetic complications. Dr. Nafisa was mentioning about a number of them, like retinopathy, nephropathy, neuropathic foot ulcers, a number of things. And also, there are studies which have shown that people having periodontal diseases or disease of gums have got a higher risk of developing type 2 diabetes. And these are all scientifically proven facts. I started my presentation by talking about comorbidities. And what comorbidities basically means that disease do not occur in isolation. Usually there are a set of disease which occur together, and they affect each other. They affect the prevalence, or they affect the worsening of the other disease condition. And it's the same case with diabetes and oral health. Like, for example, diabetic kidney diseases can lead to renal failure, which has an impact on oral health. Because if your kidney fails, then you're put on immunosuppressants and a number of other drugs, which have got a direct impact on your oral cavity and leads to poor oral health. There are diseases like depression, which can lead to neglect of oral health. So if you are diabetic, if you have got uncontrolled diabetes, it can lead to depression. And this depression can lead to neglect of oral health and further exacerbating chronic conditions like diabetes. And there are a number of studies which have actually shown that if you maintain your oral health, if you maintain your oral cavity properly, if you maintain proper oral hygiene, then it can lead to a reduction in HbA1c level, or it can help in better management of people suffering from type 2 diabetes. So it's very important to maintain your oral hygiene. So the take-home message here is that physicians who are treating diabetes should always look for oral conditions and refer patients to dentist as and when it is needed. And it is the duty of the dentist also, which should look at the early signs of diabetes and should refer the patient wherever possible to a diabetologist or a physician. So how to stop the risk of diabetes? You have to add fresh fruits and vegetables to your diet. You have to increase your physical activity, and you have to reduce sugar intake in the food. Most important thing is reducing this sugar intake. Now, when we start talking about sugar, there are a number of misconceptions which are going around, in the society. Now, there are two kinds of sugar which you can encounter. One is the natural sugar, which is found naturally in foods such as fruits and the natural sugars which are present in milk. And then there are added sugars which are present in which is added externally, like in soft drinks, candies, fruit drinks, ice creams. And it is these added sugars which are a problem for us, because they contribute to additional calories without adding any nutrients. And these added sugars lead to various problems of oral cavity as well as diabetes. So it is very important for us to control this added food items with added sugar in our diet. And this is what WHO recommends, that the oil in your food should not exceed 5 teaspoons, and sugar should not exceed 12 teaspoons a day in your diet. Basically, what this means is that the amount of additional or the extrinsic sugar which you can take in a day should not be more than 10% of your calorie consumption in a day. And ideally, it should be brought down to 5% of the calorie consumption. So if you are taking sugar, you should keep in mind that you should not exceed 12 teaspoons in a day. Now, where are we getting our additional sugar? Now, in different age groups, there are different ways by which you get this additional sugar in your diet. But if you look at the yellow parts of the pie diagram, which is shown for different age groups, maximum amount of sugar which we get is from soft drinks or sugar sweetened beverages, and consumption of cereals, cakes, and biscuits. And this is across the age groups. Whichever age group we talk about, these are the two major factors which contribute to additional extrinsic sugar. And these are the things which we should control in our diet. In order to maintain this diet, it is very important to make healthy choices. Now, these healthy choices can be conscious, and these conscious choices can be well informed. So if you go to the right source, if you look at the right evidence, or if you look at the right kind of literature, they can be well informed. If you're not looking at the right kind of literature, or if you're not looking at the right source, they can be ill informed. The choices can be conditioned, and it depends on a number of things like marketing and promotion of products. So if sugary products or if unhealthy products are marketed and promoted a lot, obviously people will try to take them in. Or these can be dependent on various cultural factors. Like, for example, the part of the world where I come from, today is one of our biggest festivals. And we have been eating sweets from the past 3 days, and we will continue to eat sweets for the next 3 days. So there are various cultural annotations which are involved when we make our choices. And we have to keep that in mind. Choices can be compelled also. Like, I may be very well informed. I may know what is right and what is wrong for me, but I have to make a compelled choice depending on the availability and affordability of things. So the bottom line here is that we have to ensure that healthy choices are the easier choices which are available. However, in reality, what we see is a mismatch between science and commerce. And we have to be very careful about this. Things which we should eat occasionally are the things which are advertised the most. things which we should eat in moderation, or things which we should eat in plenty, are the things which are either not advertised or advertised the least. And if, when I was talking about, I'll just go back to my previous slides, marketing and promotion. If you see the major part of the pyramid consists of advertisement about colas and sugary drinks or biscuits and chocolates, obviously you will be inclined to consume them. So we have to be careful about this mismatch. There are various dental do's and don'ts. I'm not following many of them, but it's very important that you rinse your oral cavity after every sugary meal or after any consumption of sticky food. Try to eat healthy food. Try to floss teeth whenever possible to minimize food impaction. Visit your dentist regularly. Brush your teeth twice a day. Reduce alcohol, reduce sweets. I think you know all these things. I would just like to spend 2 more minutes on the way to brush our teeth. And this is something which we all fail. And before joining dental college, this was a problem with me also, that we have no idea on how we should brush our teeth. And normally what we have to follow is a circular motion over the visible white portion of the teeth. So if I join my jaws like this, I have to do a circular motion for my front teeth, as well as the teeth, as well as the chewing surfaces of the teeth. And then to clean my gums, I have to do a sweeping motion. So for the upper jaw, it has to be a sweeping motion from top to bottom. And for my lower jaw, it should be from lower to the higher quadrant. So sweeping motions between the gums and the teeth. And for the white portion of the teeth, chewing portion of the teeth, it has to be a circular motion. Now, there are a lot of questions about what kind of brush is important for us. Now, there is no rule of thumb, or there is no such thing as a good brush or a bad brush. It depends on a person's need. It depends on your comfort level. So if you are someone who can handle a straight handle brush, that's the most easy and conventional brush to use. You can also use a contra-angle brush. For example, it increases the access to the backside of your oral cavity. So it is good to clean difficult areas. Then there are flexible handle brushes which are available where, it is for those people who apply excessive pressure on the teeth, which is not required. People, in order to get good grip, have got rubber handles on their brushes. So there is no golden rule, or there is no set rule that this brush is good or this brush is bad. It depends on a person's need, and any and every brush is good. Then there is also a thing about putting in a lot of toothpaste on the toothbrush. Well, that's not required at all. Actually, you're doing harm to yourself if you're putting a lot of toothpaste on your toothbrush. We just require a pea-sized blob on your toothbrush. That's it. This will do the work. The most important thing is the motion of your hands, your wrist. If you are doing circular motion and sweeping motion properly, toothpaste has got a very limited role to play in order to clean your teeth. And then always remember that you should have a fluoride toothbrush, toothpaste, which you should use. And try to stay away from desensitizing toothpaste until and unless it is prescribed by a dentist, or the whitening toothpaste, because they cause more harm in long run. They might give you that whitening thing, but they cause more harm in the long run.
Okay, thank you, Manu. I think the link you can put in the chat box due to the time, so we can share with them.
I'll share this link. So this is something which we prepared for one of our projects. This is a video which gives you some information about how you can responsibly consume sugar. We'll put the link in the chat box, and
yes,
if you are interested, you can look at the video. Thank you. Thank you very much.
Excellent. Just stop the viewing. Yeah. Okay. Thank you, Manu. Actually, I learned a lot today from how to brush, and also importance of dental hygiene. It's very basic and fundamental, but I don't know how many of us know this kind of back information. It's very simple but very bold information. I really appreciate your very easy way how to individual level to population level we can take care of our health. Now I think the time is very limited. I would like to one or two. We have a very expert PDG Dr. K. Mean is here. He can comment on anything, please. He's our PDG dentist. So Dr. Kai Min, you want to say anything? Add with Dr. Manu?
Very good presentation, precise and concise, enjoyable. Well done.
Thank you. Thank you.
Thank you, sir. Thank you.
Thank you.
Excuse me, sir. I am also a dental surgeon, Dr. Sonia.
Okay.
So I really enjoy his session.
Excellent.
Yes, sir.
Dr. Shafi, Mike Sarin here.
Oh, go ahead.
Dr. Manu, is there a general guideline about frequency of visits to your dentist?
Very good question.
No, sir. If you look at the textbooks, it says that you should visit your dentist every 6 months, but evidence says that this is not the case. It depends on the need. It depends on what is the condition of your dentition. You may be required to visit a dentist every 3 months. You may not be required to visit a dentist even for 12 months. But it depends on your dentition, and your dentist your dentist will be able to tell you.
Thank you.
Excellent. Actually, sometimes we think about insurance. My insurance covered 2 times a year, so I visit 2 times, just something like that. So there is so many misunderstanding and miscommunication. Appropriate information I got today. Thank you, Manu. Hopefully we will move on, and I really appreciate Manu. Let's give a big clap to Manu. And I am happy to all the participants today. And today we make all the historical record, previously 5 seminar. As of now, 76 participants is kindly joining us, so which is we beat all our previous record. Thank you all. And I think next is we discuss about the individual and clinical health from Nafisa, and population and dental and other fundamentals from Manu. Let's go with our young champion who is working for our community to make it happen. Sometimes we know many information, but we know many knowledge, but we never practice. And but if young people come forward, and then maybe we must listen to them. Let's go with Shudipta and Amina. Who is going to present Shudipta and Amina? Maybe Agapaya?
Yes, I'm.
Go ahead.
I'm pleased to introduce our next 2 presenters, Shudipta Islam and Amina Khan. So Shudipta holds a Master of Public Health from the University of Toronto with a dual specialization in global health and community development. Her personal and professional interests lie at the intersection of health, social justice, and policy. She is particularly passionate about how race and racialization interact with social determinants to create stark health disparities across communities, and how policies can shape healthy environments. In addition to her work with diabetes for South Asian youth, Shudipta has worked at the City of Toronto, conducting research to assess the socio-political landscape of the Ontario Works program, and at Youth Research Evaluation Exchange, consulting Ontario's grassroots youth sector to develop and conduct evaluations. Currently, Shudipta works at the Wellesley Institute as a Community Violence Exposure Project researcher in partnership with the City of Toronto. Our next presenter is Amina Khan, who is a Master of Public Health graduate from the Dalai Lama School of Public Health. She holds a degree in kinesiology and health sciences and worked as a nutritionist prior to her graduate studies. Amina's work, volunteer, and research experience span from the grassroots community level to public health governance. This experience has led her to work at organizations such as Polycultural Immigrant and Community Service, the South Asian Adolescents Diabetes Awareness Program, Princess Margaret Hospital, and the Public Health Agency of Canada. Amina's passions lie in the intersection of health equity and social justice, as well as finding ways to use the arts to address health inequities. I'm really happy to have you today, so the floor is yours.
Thank you so much for the introduction, Agafia and Dr. Bhuiyan. I'm going to share my screen, so please let me know if everyone can see it okay. Yeah.
Good.
Thank you so much for the introduction, Agafia, and hello to everyone here today. So today, Amina and I are here to talk to you about the diabetes action and prevention among South Asian youth in Ontario. Before we get started, I just wanted to make a quick note. The two of us, we're presenting from Toronto, Canada, and we just wanted to take a short moment to acknowledge the land that we live and work on. So with that, we'd like to recognize and acknowledge that the land we're on today has been the site of human activity for 15,000 years. And many Indigenous nations have long-standing relationships with this land, which far and long precede the establishment of our institution. This land is the territory of the Huron-Wendat and Petun First Nations, the Seneca, and the Mississaugas of the Credit River. Apologies there, I couldn't unmute myself. To just continue off of what Shudi was saying, as South Asian immigrants and settlers on this land, we are not only cognizant of the historical injustices which have taken place and continue to take place in Canada, but how these injustices allow us to reap the benefits of this land today. There is an ongoing need to make right with all of our relations. So hello again, everyone. We'd like to start by thanking Dr. Bhuiyan for granting us the opportunity to be with you all today, to speak alongside such incredible speakers that had wonderful presentations. It's great to meet all of you virtually, and thank you for joining us.
I think, Amana, your sound system is echo, making some vibration.
Okay.
Internet connection seems unstable.
Unstable. Can you hear me okay, or is
now
the
okay? But there is a background something echo.
There's an echo. Okay.
I can hear okay.
You can hear
Yes.
okay.
Okay.
If it happens again, someone just jump in because I can't quite see the chat.
No, okay, go ahead.
I'm going to try to keep an eye on both, but yeah, let me know if it's unclear. Yeah, so we were just introducing ourselves. So my name is Amina Khan. And my name is Shadipta Islam, and we're both public health professionals, and we're coming here from the South Asian Health Research Hub, also known as SAHAR. SAHAR is based out of the DALYS School of Public Health at the University of Toronto, and it's comprised of a network of scholars, health professionals, students, and volunteers from a diversity of age groups, genders, and ethnicities. And we're really committed to advancing the health of South Asians in Canada through research, practice, and advocacy. So before we get started today, I'd like to give you a quick overview of our presentation. We're going to be starting with a brief explanation of the diabetes landscape in Canada and also amongst South Asians living in Canada. We'll then be talking about the diabetes intervention and prevention program that SAHAR has been working on over the past couple of years. And finally, we're going to be leaving you with some key learnings and takeaways from our experience with this program. So from a very big picture, and as many of you are aware, diabetes prevalence is on the rise. The global prevalence of diabetes has risen exponentially over the past 10 years, and this trend has been particularly apparent with type 2 diabetes specifically. This trend is really owing to a transformation or an evolution of sorts to a whole host of modifiable as well as non-modifiable risk factors. And the latest data suggests that globally around 500 million people have type 2 diabetes. Canada is certainly not immune to this trend. In Canada, over 2 million Canadians are currently diagnosed with diabetes, and this chronic condition is on the list of the top 10 leading causes of mortality in the country. One province in particular stands out with regards to this, and that is the province of Ontario, the one we are actually currently speaking from.
The diabetes prevalence rates in Ontario is not only higher than the national average, but one of the highest in the country. And we're only seeing increases in these numbers. Now, the story doesn't quite end here. The risk of diabetes is increasing, yes, but not everyone experiences the risk in the same sort of way. So compared to other ethnic groups, South Asians face disproportionately higher risks of type 2 diabetes. South Asians comprise of about 20% of the world's population, but experience rates of diabetes that are 50% higher than the general population. Canada, again, is no exception to this trend. The South Asian diaspora represents one of the fastest growing minority groups in the country, but the diabetes numbers amongst our population are stark. So South Asians living in Canada are actually 3 to 6 times more likely to develop diabetes compared to white Canadians. South Asians also report higher rates of insulin resistance, metabolic syndrome at lower adiposity. And while the prevalence of diabetes is highest in the age group of 50 years and older in the general population, South Asians are actually diagnosed 5 to 10 years earlier. Now, within Canada, one region actually stands out exceptionally for its high rates of diabetes, and that is actually the region of Peel. So Peel region consists of the city of Mississauga, Brampton, and the town of Caledon. And to give you a better sense of what Peel is like compared to the rest of Ontario, Peel has a younger population, fewer people living alone, more persons who identify as being a part of a visible minority, and much, much higher rates of immigration. Peel has a couple of areas of concentrated population within central Mississauga and downtown Brampton, but in general, it's characterized by its low population density. And so the reason why we bring this up is because the design of the city is strongly associated with higher car use, and the city's structure doesn't really lend itself well to things like walking or cycling. And on top of that, a lot of recent immigration to Peel actually has been from regions of the world with high rates of obesity and higher rates of diabetes. So with some of these characteristics in mind, we see that the diabetes numbers in Peel are very high. Currently, 1 in 10 adults in Peel has diabetes, and by 2025, that number is projected to be about 1 in 6. And most notably of all, Peel happens to be home to 1/5 of Canada's South Asian population.
So you've probably gathered by now that diabetes poses a pretty significant risk to the South Asian community. And unfortunately, this threat is exacerbated by the fact that diabetes risk is transmitted intergenerationally. What we're seeing is not only that children are at an increased risk of type 2 diabetes because of their family histories, but also that they face these risks at younger and younger ages. And this trend is actually a pretty stark contrast from the more pervasive ideas that diabetes largely only impacts adults and seniors. So this leaves us with a challenge. The challenge to break this cycle by increasing awareness for youth who will go on to become the next generation. So to address this, the Sahar team implemented a program called the South Asian Adolescent Diabetes Awareness Program, which is also known as SADAP. SADAP is a multi-phase project which targets South Asian youth in the Peel region with a family history of type 2 diabetes, so either parents or grandparents. And SADAP has 3 key objectives. The first is to increase healthy behaviors related to physical activity and nutrition. The second is to increase general diabetes knowledge and awareness in relation to the social determinants of diabetes. And the third, which is to foster knowledge mobilization and advocacy. So phase 1 of the SADAP program consisted of a diabetes awareness and education program that was piloted back in 2018. We're going to play a short video on this program to give you a better sense of what SADAP was like.
Plus or not?
this is a health promotion program, but it's not simply a health education program. We're not simply just asking or teaching the youth how to exercise and eat properly. We know those are important components to help reduce their risk of diabetes, but we have a whole social advocacy piece that is part of this program. What we're trying to do is understand and explore what we call the social determinants of health, really acknowledging that there's a huge variety of factors that impact the health and quality of life of our participants. So we're having conversations about food insecurity, food access, body image, the built environment in the neighborhoods that our participants live in, the school environment where they spend so much of their time. So it's really important for us to look at diabetes prevention holistically like that, so that we can take a multi-level approach and hopefully help these youths make lasting changes throughout their lives.
So the program includes meetings with dietitians.
So for the sake of time, we just showed you a small snippet, but if anyone's interested in watching the full video, please get in touch with us and we'll be happy to send you a link. It's on the Sahar website. But we just really wanted to give you an idea of what SATUP Phase 1 looked like. And the pilot program actually caught the attention of, caught a lot of attention and even had a feature article in the CBC. And the research team, observed a couple of really interesting things from the first phase. For the sake of time and your interest, I'm keeping the findings pretty high level here, but what we saw amongst our participants was that there was an increase in healthier food choices and physical activity, which, as you probably already know, are two of the most important modifiable risk factors when it comes to type 2 diabetes. And in addition to that, we also observed that there was an increase in them encouraging other people in their networks to also engage in healthier lifestyle choices, like their friends and their family. And to an extent, some of these results were to be expected, right? There is a lot of literature out here showing us that lifestyle interventions do have a degree of success in creating lifestyle changes in either the short, medium, or long term. But what was really striking to us as a team was that despite the increases in making better lifestyle choices, our participants' risk perceptions of diabetes didn't change in almost half of our sample. And actually, the risk perception increased in about 20% of our sample. So considering lifestyle choices on its own wasn't sufficient. And so there was this really big picture here that we needed to consider. And so that's where SATUP really began to evolve as a program. We really wanted to shift the narrative from saying change your lifestyle into why do we have the lifestyle that we have. We didn't just want to have a conversation about modifiable risk factors. In the case of diabetes, things like diet and physical activities as key ones, but we really wanted to contextualize them as well. And we did this using a model called the socioecological model, or the SEM. So the SEM framework really just asserts that your lifestyle is directly impacted by the environment around you. And the SEM framework shows us that your behavioral choices are not only a subset of your lifestyle, which is at the individual level. So it's the individual choice to lead a healthier life, but our lives are also heavily influenced by other things like the immediate people around us, people like our family, our close friends, our partners. And it's also impacted by the institutions we go to, the communities that we're in, and by the governments that we live under. So as a team, Sahar was really, really mindful that if you wanted to break the cycle of diabetes in the South Asian community, especially by targeting the youth population, then we really wanted to implement an intervention that was holistic and took into account the different levels of the SEM.
So as Shruti explained, to really take that conversation further and address some of those upstream factors, we worked with the youth in the second phase of this program. So the second phase of this program was actually a photo voice project under the name of Beyond the Body. And much like the title of this program, the purpose was to engage in youth in that conversation, in that knowledge, in that awareness that really went beyond just talking about lifestyle behavioral factors. We didn't want the awareness program to solely be centered at the individual level. So we didn't want to just talk about what we're eating and how much we're exercising and how that affects diabetes risk. We wanted to push them further and start thinking about those broader forces that moderate these choices. And so we centered the conversation on those broader determinants of health, or as we call them, the social determinants of health. And again, thinking back to what Shruti explained, that socio-ecological framework, we encourage the youth to think about ideas of how the people around you impact your health and your lifestyle, how the institutions we go to, like where we work or where we go to school, impact our choices, and how our community or neighborhoods can change our health. And finally, what kind of policies are in place to govern the kind of choices that are available and accessible to us. And so in order to do that, we used an arts-based research method called photo voice. So photo voice is essentially a research method which uses photography and stories about these photographs as a means to represent issues of importance. So for Beyond the Body, photo voice was a research but also critical thinking method that helped enable these South Asian youth to explore their experiences of diabetes risk, share those experiences, and then also work to collaborate and advocate for their community. So as a result of this project, we actually had about 18 photographs and captions from the youth participants. And what you see in front of you on the slide is actually one of them. So each photo captured really speaks to the upstream factors that are pertinent to their individual lives. And in this photo in particular, we see a bouquet of flowers that's on a bench. And in the caption, we see that the participant is talking about how these flowers aren't able to thrive because they're not in the right environment. And so the youth really use this as a metaphor for the experiences of immigrants who have qualifications and education, but aren't able to use those because they're in a different system where their experiences aren't considered as valid. For the sake of time, I'm just going to skip over the next photograph. And I'm going to quickly jump to our Youth Health Awareness Council. So we mentioned the program started in 2018 and it came to a wrap up earlier this year. But after completing the SADAP program and the Photo Voice project, a group of 9 adolescents continued to work with our research team and actually formed this Youth Health Awareness Council. So afterwards, we continued to meet with them to build on some of the ideas that we did in the research study and really help mobilize their work in health equity. A major objective of the council is to teach South Asian youth on how to use their personal and educational power to contribute to more positive health promotion and healthcare experiences for their community. And to put faces to the name, these are them. They are a group of amazing young female South Asians between the ages of 15 and 19. They are dedicated, passionate young minds that want to mobilize and become agents of change in their community. And Shruti and I have had the pleasure of working with them for the past 2 years, and the growth that we've seen in them, the confidence, the learning has been truly inspiring. And so we went from really teaching them things to now working alongside the Youth Council, where we are currently working with them on a project for the Canadian Cancer Society, and they're helping to inform this marketing campaign and increase representation of South Asian women within that campaign.
So SADAP is really an example of kind of this urgent need to look at the complex, multidimensional nature of health and of diabetes. I think too often we ask people to change their lifestyle for the sake of health without really considering, how do the socio-political and ecological landscape around them, how do they act as barriers or facilitators to these changes? And for us, it was essential to hear about what our youth participants had to say about these unique experiences with things like immigration, their school policies, their societal expectations, and even broader systemic issues like food insecurity and racial disparities. It was so essential to understand the type of environments in which they live in, work in, and play in. And it was really important for us to not just stop there. Once our youth participants were engaged in these critical discussions, they had this momentum to create change through advocacy and action. And they went from being participants in like a research study to being agents of change. And so that's how we were able to really mobilize research and knowledge into action. So we want to leave you guys, the audience, with 3 kind of key takeaways from SADUP. And the first is that, lifestyle matters, but prevention and awareness initiatives need to adopt a holistic framework to inform their understanding. And the second is youth are really indispensable catalysts of change. I think often we think of youth and, we think that they might not have capacity or power, but they actually have a lot of strengths to give us, and they have a lot of capacity to make change in their communities. And community mobilization is really an essential part of health promotion work, and you really can't do it without mobilizing the community. We'd also like to share that Sahar is producing and launching a short film, which will be featuring all of our youth participants and their photographs in our Beyond the Body virtual photo exhibit event. It's really a one-of-a-kind visual production on a key public health issue, and it's going to be coming in January of 2021. This short film is actually being produced and edited by Amina and myself, and collectively, we actually work together on several projects that look at the intersection between the arts and social and behavioral health sciences. And using things like photography, graphic design, videography, and art, we've really cultivated this diverse and innovative and creative way to advance the mission of public health. So we're really excited about the film, and we invite all of you to join us for the event should it interest you. The registration link will be made available in the coming weeks, so please feel free to get in touch if you're interested. And we also wanted to just take a quick moment to acknowledge our wonderful team and our principal investigator, Dr. Ananya Banerjee, as well as our partners and funders from the Lawson Foundation, Diabetes Canada, and the Social Sciences and Humanities Research Council. Please feel free to ask us any questions. And if you don't have enough time for discussion today, please don't hesitate to get in touch with us.
Thank you.
Thank you.
Thank you, Shudipta and Amina. Very impressive. And yes, the young and youth, our treasure. Your support matters to change the societal needs. And you guys, very simplified way, precisely try to understand, explain us how important the work you are doing. So I really, again, congratulate you. I ask all the participants kindly give a big applause to Amina and Sudipta and the team.
Thank you.
Background information is, I know time is exactly 8:30, but we always continue. A few more minutes. One thing I would like to share with the Lions and the guests and governors that I work with EFT, very high level professor, Dr. Nania, and I also sitting with the committee for Better Women Project as an advisor to the GTA, especially Peel Region People's Health. That's the way I met Amina and her team. And I found they're very exciting job they're doing. We should know, and we should learn from them because learning is endless. That is why I invite them. I think this is the best day today. Canadian, we observing 100 years of Lionism in Canada, and also Diabetic Day is a special day as WHO started 1991. And for that reason, I want to present you something new, but something very interesting who would be a very good change agent for us, for our society, for our community. Okay, dear Lions, now floor is open. I will take your any question, any comment, any discussion, and then go from there. Anyone?
It was a great presentation. I learned a lot from that, and I really enjoy these sessions. And it's great, and it's great to have this venue that we can share.
Yep. So we'll make this video available of the Lions District A711 website and also our club website.
I'd like to give thanks to all that presentation. I learned so many new things. Even I have diabetes 60 years. So many new things has been coming and good to help with the younger generation and type 2 diabetes now ahead. Thank you very much for what you're doing, and keep doing the same good work, and we could have very good diabetes-free Canada. Thank you.
Yep. Yeah, that is the dream, Governor, PDG. We want end diabetes, like end HIV, everything we want end, but it's a long process, and we are just one step ahead and one step at a time. Any other feedback, comment, suggestions?
Dr. Shafi, can I speak for a minute?
Of course, sure. Go ahead.
Hi, thank you everyone. My name is Shahin Chaudhuri. I'm a Ryerson Ph.D. university student. Dr. Shafi is my senior brother. So I would like to thank you everyone for your wonderful presentation. Sorry, I'm not a doctor, but I'm a type 2 diabetic patient for last 7 years. And I will tell you one of my experience. I was taking insulin and metformin and so many other medications, but things were not actually working for me. But for the last 3 months, I have changed my lifestyle modification. I am just now, I stopped all types of carbohydrate. Now I am just taking only protein, fat, and vegetables, and also doing the regular exercise with a little bit of apple cider vinegar twice a day. And the results are fantastic. I stopped insulin, I stopped metformin, but still my sugars are in control. And so that's why I want to tell you that lifestyle modification matters, diet change matters. So the more insulin I was taking, the more I was getting more sick and doing really bad. So I want to tell you, like, is there any test that can determine, like, what is the reason for this patient to be diabetic? Is it for insulin resistance or for something else? So if there is any test that could determine like that your diabetes is a result of insulin resistance, then I hope patient should not take insulin anymore, because the patient is already insulin resistant, and by taking more insulin, the patient will become more insulin resistant, which has, I believe, happened on my case. So whenever I stopped taking insulin and I started doing my 360-degree lifestyle modification change, things started working for me. So I believe whenever you doctors talk, you should actually accommodate this diabetes resistance and how these happen, and what are the ways to remove the diabetes insulin resistance. So I believe that is much more important to talk about. That is working for me, at least for me. So I believe my experience can give a little bit focus to your further discussion. Thank you for having me in this forum. I'm not a member in the Lions Club. I'm just a friend of Dr. Shafi, but I would like to share my experience. I believe it helps everyone. Thank you so much.
Thank you. Thank you. Yeah, actually diabetes is a bigger thing. So not only one size fit for all, everybody has different perspective, different needs. The limitation is the provider. As a provider, maybe we need to listen people. I think patient is the most diagnostic tool. If we listen carefully, and actually we can find the root cause. Maybe we have something we are missing. And any other thought, Dr. Mike, would like to share?
Yeah. So
Please.
what the young man has done is he has turned off the glucose intake. So by eliminating glucose or sugar producing foods in his system, he's relying on protein as the source of energy in his body, and protein is getting converted partially into glucose in the body. That's good. Unfortunately, it's very difficult to maintain this kind of lifestyle, Shaheen, for long term.
Yep.
Most people get back to eating some glucose. So I don't know how many grams of glucose you're taking daily. If you are taking about 15 grams per day, you're really on ketogenic diet. If it's moderate, you might be on 15 to 50 grams, and after that, it becomes harder and harder. So
Just give me a
diabetes is
moment,
nothing
Auntie.
but intolerance to glucose producing foods. So you have turned off the glucose production. That's why you are off insulin and you are reaping the benefit, at least for now. Be very watchful because there are complications of ketogenic diet, particularly presence of kidney stones and such things. So you have to be very watchful.
Thank you.
Thank you.
Okay.
Thank you. And any others? So
Great presentation. Great celebration World Diabetes Day. Congratulations.
So let's thank all the presenter, all the participants, and we can turn off the video and then we can informally discuss those who are here. So thank you all for your great presentation and to participate today's World Diabetes Day, our District A711 Diabetic Seminar, awareness seminar. Thank you again.
Thank you.